Hello everyone. So today we'll talk about burns and burn injuries and also nursing management. So, burns occur when there is injury to the skin or other tissues of the body caused by heat, chemicals, electrical current, or radiation. And the patient with a burn injury may have multitude of problems and also complications. But of course, there are also some preventative measures that we can educate our patient in regards to preventing burn injuries. There are different types of burn injuries, and when you're trying to answer an NCLEX question regarding this, is you have to pay attention to what type of burn injury we're looking for. Is it a thermal burn injury, chemical burn injury, smoke inhalation type of injury, electrical burns, cold thermal injury? And again, this is, with thermal burn injury, it's caused by flame, flash, scald, or contact with hot objects. And you know what? This usually happens when your patient is cooking, accidentally, you know, um, got that thermal burn injury. And again, the severity depending on the temperature of the burning agent and the duration of contact time from that specific burning agent that your patient got in contact with. So here is showing you a partial thickness type of burn injury to the hand of your patient. So I want you to pay attention to it because again, as a nurse, is we have to assess, what it looks like and how to document them. This one is showing you a full thickness flame burn. Look at the back of this patient, right? Look at the head area and the face. And remember, if there's a burn injury on the face of the patient, that technically will need an airway support immediately. Okay, airway will be your priority if the burn area is around the face and also chest. So here, another type of burn injury is chemical burns. And this is results of contact with acids, alkaline, and organic compounds. I remember seeing a news about a woman who suffered from a chemical burn injury where she was saying that somebody just throw an acid on her face, and it really affected her face and her chest. So if your patient had an alkali burns, it can be more difficult to manage because they cause protein hydrolysis and melting. So it can be found in cement, oven, drain cleaners, heavy metal cleaners. So again, it really depends on what causes it. And this is considered chemical burn injury. Now, when we say smoke inhalation injuries, by the word smoke inhalation, this is caused by chemicals that are that the patient smelled and breathed. Okay, it could be a hot air, and it can really cause a lot of damage in the respiratory tract. And another thing is when patients have this smoke inhalation injuries, their mortality rate is higher. And remember that your patient is very critical where their airway is compromised and your patient will need immediate oxygen support. Now, there are three types of smoke inhalation injuries. We have here upper airway injury, lower airway injury, and metabolic asphyxiation. Now, with metabolic asphyxiation, this is when your patient inhaled carbon monoxide and hydrogen cyanide. And like the thing when your patient had carbon monoxide poisoning is your patient lungs tend to collapse because what happens is the carbon monoxide binds to the oxygen, to the hemoglobin of the patient, and technically affecting the O2 level of the patient in the blood. And what you see is your patient's having a hard time to breathe. And when there are times when you check their O2 saturation, it does not seem correlating with what you see. So that's why the O2 saturation, or using pulse oximeter, is not an accurate measure for you to know what really is going on oxygenation wise to your patient. So that's why we need to make sure that we check the carboxyhemoglobin levels instead and see the amount of exposure that your patient had. And remember that the mortality rate also increases if we don't know how much this patient was exposed, and we need to address the hypoxia by giving 100% O2 to this patient. Okay, and it may occur in absence of burn injury, so you want to make sure that you assess your patient thoroughly. Okay, so when you say upper airway injury, this is when your patient had injury to their mouth, oropharynx, or larynx. It could be caused by thermal burns, or your patient had an inhalation of hot air or smoke, and that causes burns around the oral area and larynx. So when you look at your patient, they might have blisters in their mouth and the surrounding area, and you might see some edema. So when you look at their face, it looks very swollen and red. And remember, once that happens, that tells you that the airway and breathing are already compromised. And especially if they have edema and burn injury around their face and neck, that can be very lethal, because that means that really the airway and breathing are compromised. So you want to make sure that that's your priority. This patient will really need airway support. Now, when it comes to lower airway injury, we're talking about the trachea, the bronchioles, the alveoli. Is this patient will have tissue damage related to the exposure to toxic chemicals or fumes or smoke. And again, even though it's lower airway, remember, is we have their very important part of the respiratory system, which is alveoli, where the O2 and CO2 exchanges happen. So this patient, again, can develop ARDS, or acute respiratory distress syndrome, that really predisposes them to have poor prognosis. Now, when you assess this patient, if they have lower airway injury, again, look at their face, look at their swallowing reflex, look, and assess and ask the patient, is there any painful in swallowing? How's the nasal membranes? How's the oral membranes? Is it darkened? Did it change its color? Does your patient have an sputum production? How's the neck? How's the chest? So you want to make sure you assess your patient. Now, when we talk about electrical burn injury, this one is different from what we talk about, but here is your patient will have a direct damage to their nerves and vessels. And this can cause tissue anoxia and death to your patient. And this is caused by intense heat generated from an electric current. Okay? So this is an example of electrical burn at the back. So look at that. Look at that. Okay, so again, here you will also see electrical burn in the leg. Look at that. Okay, that looks really bad. That can cause tissue anoxia and death of the tissues. Okay, now the severity of injury depends on the voltage, or the amount of electricity that your patient had. Okay, that's why this is when your admission assessment comes in, what causes it, what happened to the patient. Some patients will tell you that, let's say it was raining, there's hurricane, let's say the roof went off, and then let's say something is plugged in, and accidentally, with the water on the floor and all that, causes that spark and cause electrical burn injury. That can happen. And again, you want to ask if this patient, what length of time that this electrocution happened and sustained. Okay, and again, when it comes to electrical burns, it can pass us through vital organs, and it can be life-threatening to your patient. And remember, it can also ignite, with the patient's clothing, causing a thermal flash injury, which will cause further damage to your patient. Now, again, the severity, assessment happens when you look at how much damage happens below the skin, and if it causes muscle spasm, is it strong enough to fracture their long bones and vertebrae? And this can happen. So imagine they already have electrical burn injury, plus you have to take care of fracture. Okay, and you guys know that when it comes to fracture, there are many complications that are connected to it, especially if the long bones are affected. Now, when your patient has electrical burns, I mentioned earlier that prognosis might be poor to some of these types of burn injury. And the thing with electrical burns, your patient can have cardiac arrest, they can have dysrhythmias, because just imagine being electrocuted, right? So with that, that can also cause severe metabolic acidosis. And this is not good because this also tells you that the kidney function is failing. Okay, and when you look at the myoglobin level, you might see some myoglobin in the urine, and also this tells you that this is released from an injured muscle and hemoglobin from damaged RBCs. And this happen when there is an injury going on inside the body, and it can travel to the kidneys, causing more problems, which are acute tubular necrosis and acute kidney injury. And if you remember, acute tubular necrosis is a type of intrarenal acute kidney injury. Now, classification. Again, the severity depends on the depth of the burn, the percent of the TBSA or total body surface area, the location. And as I said, if it's in the face and the chest, that's not a good sign. That means airway is compromised. Make sure that you get comfortable on calculation of TBSA. This is very commonly asked in exams and also in your NCLEX, okay? And we will discuss it. Another thing that you need to assess is the age of the patient. What happened before the burn injury? What's their medical history? What are the complications that may arise based on what your patient has? Now, this is just to give you a review of the cross section of the skin. Okay, so when you look at this, if the burn injury happens between, the epidermis in here, that is a superficial partial thickness or first degree burn. Okay, now once it gets deeper here, affecting the epidermis, the dermis, and affecting also some parts of the subcutaneous fats, that we can consider deep partial thickness or second degree burn. Okay, and if it affect all the way down to the fats, the muscles affecting the bones, that is a full thickness or third and fourth degree burn. Okay, you might remember this partial thickness, full thickness when you are learning about pressure ulcer, right? Because it seems the same when you label them, but this time you're labeling them as degree of burn injuries. So when you document them, this really matters. Now the depth, again, we talk about already the degree of the burn, whether it's first, second, third, or fourth degree. And again, the depth or how deep it is we're looking at partial thickness, full thickness burn, and that's the one that I showed you earlier in the previous slide. Now, I already discussed this part, so I'm gonna skip this slide. So there are two common tools for determining the TBSA. So you can use the Lown-Browder chart. This is considered more accurate. You can also do rule of nines as your initial assessment because most of the time it's easy to use this one. And as you can see in here, this is at the land Browder chart. And as you can see, this is 3.5. This is scored as 1. This is 2. This is 13. So again, I would recommend for you to look at it, and we will have some activities in using land Browder chart and also the rule of nines. Okay, the rule of nines is very commonly used in NCLEX. So in terms of memorization of the chart, I would recommend for you guys to memorize the rule of nines. So let's say um, somebody gave you a report that, hey, this patient had a chemical burn injury on the upper and lower chest. That would be 18%. And let's say the nurse also told you, hey, and also the face and the back of the head are affected, so that would be 4.5 for the face, and the back of the head would be another 4.5. That would be 9%, right? So in short, 18% plus 9, that's 27% of burn injury. So you see, and we will discuss this more. And again, please get to know this one. As you can see, 18% upper and lower, that's 18%. Anterior and posterior is the same, 18%. Same thing with the arms. The arms would be 4.5 bilaterally, front and back. Same thing with the face and the back of the head. And for the legs would be 9%. Okay, and also for the genital area, private area, that would be 1%. Okay, so please know this because you will be tested on it. Now, the severity of burn injury is determined by location. So again, if it's in the face, neck, chest, airway is compromised. If it's in the hands, on their feet, on their eyes, then self-care would be hard for those patients. Because just imagine having those injuries there. They will not be able to clean themselves. They will not be able to give themselves a bath, or at least, later on, trying to walk to the bedside commode. It will be hard for them. They really need a lot of help. And if their injury is in their ears, their nose, their buttocks, their perineum, then they're at high risk for infection, because if there's an opening there, that is really room for the microorganisms to go. Now, remember that with circumferential burns of extremities, it can cause circulation problems distal to the burn. So don't think that if the hand is only affected, that their arm circulation, the circulation in their arm will also be affected, and nerve damage can happen. And since nerve damage can happen, your patient can develop compartment syndrome. Again, when you assess these patients who have burn injuries, earlier I mentioned to you that upon admission, you have to check their medical history, because that gives you a heads up on their prognosis. Because if they have pre-existing disease processes, let's say they have heart failure, kidney failure, plus they have burn injury, that's not a good combination. Now, another thing that can be challenging for the patient to recover is if they are alcoholic, or if they have been using recreational drugs that are not good for them, because that can hinder their recovery in a way that, for example, if you're trying to um, give them some sedation, you might also need to think your patient might have alcohol withdrawal syndrome. So keep that in mind. And another thing is, if they're malnourished, then you want to make sure that, let's say, if their burn injuries on their face, neck, mouth, then you cannot give anything by mouth. You cannot, you know, especially if the burn injuries in their nose, then insertion of NG tube might not be an option. So TPN can help on this type of situation. Now, what if they have burn injury in their arms too? So that's another thing that we need to think about, that, okay, they cannot have any central venous access device on their arms. So for sure, the Central line will be put in their groin. Things that you need to think about when you're taking care of this patient. Now, pre-hospital care. So if your patient, let's say it's at home and had this burn injury, our priority is for that person to be removed from the source of burn and stop the burning process. So the rescuer, whoever that is, need to protect themselves also and remove the patient from contact with the source, whether it's electrical or chemical burn injuries. Now, if your patient had a small thermal burns, they can cover it with clean, cool, tap water, dampened towel. That will help also with the discomfort and pain. And cooling within a minute helps minimize the depth of injury if it's a small thermal burn injury. If it's large and your patient is unresponsive, then remember to perform basic life support. So this is when you prioritize circulation, so perform chest compression and ventilation because their airway and breathing are also compromised. But if they're responsive, then we want to assess if they can still breathe on their own or if they need more assistance in regards to that, and then support it. Now, if it's a large thermal burns, then cool burns for no more than 10 minutes. Do not immerse in cool water or cover with ice because that will cause more problems and vasoconstriction and will cut the circulation. So remove the burned clothing because remember that um, that burn injury will ignite with the patient's clothing, so we have to remove it. We need to wrap our patient in a dry, clean sheet or blanket. If it's chemical burn, let's say somebody like spill or throw an acid to patient's face, like what I'm sharing to you earlier, then we have to remove those chemical particles or powder and flush that area with water so that it will not stay in the skin of the patient that causes further injury. If it's inhalation, let's say your patient was exposed in carbon monoxide and your patient's having respiratory distress, treat it quickly and efficiently. You can give 100% humidified oxygen if carbon monoxide poisoning is suspected. Now, when it comes to burn management, we have to think, is this resuscitative? This means that, is this the phase where we need to save the life of the patient like immediately? Or are we focusing more on the healing of the burn injuries? Or are we focusing on restoring, or having the patient in rehab for them to get back to a um, normal? But then remember that if they had burn injury, whatever type that is, the normal might not seem normal to them anymore, especially if it caused some damage in their body image or in any part of their body. Okay, something to think about also. So this is a sample of case study that you can work on your own. So as you can see here, what if your patient had a 46% Landbrauder chart based on that, and your patient has a large bore IV that are started and has a Foley catheter. Okay, so what would you do on that patient, right? 46%, that's huge. Okay, because remember the chest is 18%, so it means it's more than that. So there will be other parts of the body that are affected. So again, what do we do on emergent phase? Okay, on emergent phase, this is time required to resolve immediate problems resulting from injury. This can be up to 72 hours. So when you get this patient, our main concern is hypovolemic shock and edema. This is when we really give a lot of fluids to the patient, and at the same time, we have to diurese them because if they have a lot of edema. I know it seems contradicting because we're giving fluids and we diurese them. The fluids will be more on for the hypovolemic shock, but there are times, remember, that fluids are not enough, that your patient will need vasopressors like norepinephrine, right? But in addition to that, you have to remove that excess body fluids in the body. That's why we diurese them. So again, you make sure you monitor intake and output, you monitor blood pressure of the patient. As you do this, you're creating a fluid and electrolyte shift, okay? So again, that's why we have to make sure that we manage this properly. Now, this is a pathophysiology and why your patient will be predisposed to develop shock. Because remember, when your patient has burn injury, it opens up the vasculature in the body. Once it opens up and becomes permeable, then, the fluid will shift to the third space and will cause edema. But even though that's happening, is when you check the intravascular volume, it drops. And because of that, is the body will try to concentrate what it has. That's why the hematocrit here is high. And what's going to happen to the blood, it's going to be viscous, very viscous. It will become very thick. Your patient will be at risk to develop clotting. And that will cause, this decreased intravascular volume to shock due to burn. And in addition to that, you have to watch for the clotting that is ongoing. I already discussed this, so I'm gonna move on. So this is an example of a patient that had facial edema before and after fluid resuscitation. So this is before. This is after. You see this patient looks very, very swollen. And as you can see, this patient has NG tube to suction and has it's intubated, okay, connected to ventilator. And you'll see that the recovery time here is longer. Now, I already mentioned to you about the fluid shift earlier. So remember that normally we are losing 30 to 50 ml per hour. Because as we breathe, our lungs are losing about 400 ml over 24 hours, and also our other vital organs. So that's why when we replace or when we give IV fluids to this patient, you have to take note that even though you're giving, they're also losing insensibly that you don't see with your bare eyes. So you want to make sure that you do this cautiously, and you have to monitor the patient's vital signs and assess the patient. Okay, you can do focus assessment, checking edema. Is it getting better? Is it getting worse? Okay, how's the vital signs of this patient, especially blood pressure? And you want to also check the red blood cell. And as I said earlier, due to burn injury, it can increase hematocrit. And then with RBCs, they can be hemolyzed due to burn injury. So again, this can happen plus the fluid shift. That's why your patient is very sick. And you want to make sure that you replace what's lost, specifically fluids and electrolytes. Now, as you can see in here, potassium shift develops first because injured cells and hemolyzed RBCs release potassium into the circulation. So what does it tell you as a nurse? That tells you that your patient can have hyperkalemia. And too much potassium can stop the heart. Okay? So in short, when you're taking care of this patient and you're trying to drop their potassium level by diuresing the patient, you have to make sure you monitor it closely, because we don't want to lower the potassium too much. Okay? So there should be checks and balances by monitoring their electrolytes level by checking their blood. Now with sodium, as I said earlier, because of the vascular permeability, is that the fluid shift to the third space, causing this edema. But of course, by diuresing them and giving them, as I said, diuresing them means giving them diuretics, then your patient hopefully will improve when it comes, when you assess them. Now, this is just to show you the effects of burn shock to your patient. So as you can see in here is that the capillary seal is lost. That's why it creates this fluid shift of water, sodium, albumin. Okay. And then water, sodium going back. Okay, as you can see in here. And some shifting happening with the potassium, because again, it's released due to burn injury. So what's going to happen? Your patient will be at risk to develop hyperkalemia. Now, in addition to this is that your patient will have, of course, inflammatory process. So what's going to happen? The neutrophils and monocytes accumulate at the site where the burn injury is. And wound repair begins as this burn injury started within 6 to 12 hours after the burn injury. And with the immune system, of course, because of that burn injury, remember, our skin is our barrier. It's the largest organ that we have, our skin. So it protects us. So just imagine if it's destroyed, then what's going to happen? Our immune system will try to protect us as much as it can. But when you look at it, it can suppress bone marrow, and what's going to happen, the immunoglobulins will decrease and WBCs might have a defect because of this burn injury. So this is not good. Your patient will be at risk for infection. And another thing is, in addition to infection, shock due to hypovolemia, your patient will be in a lot of pain. They will have blisters on the area that they had burn injury. And the thing is, it shuts down the bowel sounds where predispose them to develop paralytic ileus. They'll be shivering because if they are having an infection in addition to burn injury, as part of the body's compensatory mechanism is to increase the temperature. So your patient can have fever, chills, and they will shiver. And again, they can have altered mental status. Now, in cardiac, since earlier I told you they can have hyperkalemia because potassium is released from the cell due to burn injury, is they will have dysrhythmias. In addition to that, they are having signs of hypovolemic shock. So for sure, the blood pressure of this patient is critically low. And again, your patient can have from tissue ischemia, can have necrosis. Okay, so this is an example of escharotomy of chest and arm. So look at that. Okay, and you might be wondering, what is escharotomy? So when you say escharotomy, it's a surgical division of non-viable eschar, the tough, inelastic mass of burnt tissue that results from full thickness, circumferential and near circumferential skin burns. So this is an objective measure that they use, and the problem here is it predisposes your patient, because looking at that incision can predispose your patient to develop infection. Okay, so we treat this incision as if it's part of the burn injury, even though it's part of the treatment. Okay, look at that. Now, another thing, earlier I've mentioned to you that the blood is very viscous. So again, we have to watch our patient for possible development of clotting somewhere, whether it's in the lungs, in the legs, in the brain. So that's why we give them IV fluids. We start them on anticoagulants like heparin, okay, so that we prevent those complications to happen. Now with respiratory system, again, if it's an upper or lower airway burn injury, again, can occur with or without inhalation, your patient will need a lot of oxygen support. And again, if it's carbon monoxide, then we have to check carboxyhemoglobin level. And we also need this patient to have bronchoscopy, especially if they can tolerate the procedure, and chest x-ray, okay, to assess their respiratory distress. And ABG also will tell you how bad the oxygenation level is in the arteries. Now, other things you have to watch for is possible of heart failure. Because again, with those brain injury and with the complications and clinical manifestations that can happen to them, just imagine this patient can have pneumonia, respiratory failure, and other complications. And with urinary system, because myoglobin, can be released due to burn injury, can affect the kidneys and can cause acute kidney injury. So again, when we manage the patient, again, our priority is airway. So you do as much as you can to support that, whether they need intubation, whether they need bronchodilators to open up those airways. You need to reposition them on high Fowlers because they need that for lung expansion. And if they need suctioning, then do it to decrease incidence of pneumonia, or maybe they need escharotomy of the chest, like the one that I showed you earlier, that is escharotomy. They need fluids. So, and to give fluids, because you will need a lot of fluids, is your patient will need large bore IV. Okay, especially if their TBSA is greater than 15%. Okay, and remember that the 18% is the chest, if you remember in the rule of nines chart, right? So if it's greater than 15, your patient will need large bore IV, but there are times your patient might need central line, especially if the burns is greater than 20. Okay, so we need these lines to give fluids, and we will need arterial line so that we can draw ABG from it, and invasive blood pressure monitoring can also be done through it. Okay, for fluid replacement, we'll be using Parkland formula for that. And of course, we have to perform wound care because this patient has burn injury and at risk for infection. So your patient will be needing cleansing and gentle debridement as ordered. Okay. Surgical debridement, it can be done in the operating room where they remove the necrotic skin, and then also doing escharotomy and fasciotomy just to release the pressure and help with the healing process. But then again, with these procedures, it predisposes your patient to develop infection. So this is an example of hydrotherapy cart shower. Okay. And this is an example of debriding full thickness burn, wherein they remove the area that has a full thickness burn to improve the healing process. I know it doesn't look good, okay, but that helps our patient. Now with wound care, again, we dress the wound as prescribed. We can put antimicrobial dressing also because it predisposes your patient for infection, and your patient can have shower once, okay, again, as prescribed if it's safe. And again, infection can cause further injury and possible sepsis, especially if your patient has a lot of escharotomy and there's so many areas of the body that are exposed. So again, we have to, there are times that we have to do open method where there is no dressing over the wound, but it's covered with antimicrobial medications or ointment. Now again, remember, wound care is a sterile procedure. You have to do it to decrease incidence of infection. So this is an example of silver sulfadiazine to moisten gauze. So that's what we apply. And remember, when open burns wounds are exposed, you have to wear your PPE. So you have to put your mask, gown and gloves, and disposable hats. Okay, and remember, when you're applying antimicrobial ointment, you need to put your sterile gloves. Because as you all know, wound care is a sterile procedure. Okay, and again, if your patient has a homograft skin from skin donor cadavers, we have to use newer biosynthetic options for them. And again, perform wound care. Now, if the burn injury is on the face, then we do pretty much the same. We don't wrap the face because it will, to limit the pressure. That's a no-no. But instead, we do an open method. We put an ointment in there and gauze as needed. And for the eyes, antibiotic ointment again can be used, artificial tears to moisten the area. And again, we have to make sure that we keep the ears free of pressure. So just be mindful when you're using pillows. Okay, but again, if they have burn injury in their ears, no using of pillows. Okay, raise patient's head with rolled towel instead. And with hand and arms, it should be extended and elevated because it helps to decrease that edema. Now for perineum, we want to make sure it's clean and dry. And especially if they have indwelling catheter, we have to perform perineal care. And if your patient is having a lot of diarrhea or loose stools, we can use a fecal diversion device, or also known as fecal management system. And never ever forget that as you do this management, you want to make sure you monitor your patient, you perform head-to-toe assessment, you check their blood, monitoring their electrolytes levels, check vital signs, assess their oxygenation. If you can also perform ROM, or range of motion, so that we prevent development of clots. Now with the drugs, remember this patient will be in a lot of pain. So we want to give them opioids like morphine, hydromorphone. We can also give them haloperidol to decrease their anxiety, and lorazepam and midazolam, okay, to help decrease anxiety and to help them sleep. Okay. They also need tetanus immunization. This is given routinely to all patients who have burn injuries. And of course, they need a lot of antibiotics in their wounds that we put. It can be topical and it can be through IV infusion. We also need VTE prophylaxis because remember, they are at risk to form clots. So with this one is they will need enoxaparin that we need to administer subcutaneously. But then again, those who are at risk to bleed, then instead of using anticoagulants, we can use SCDs, graduated compression stockings can also be used. Nutrition. Remember, nutrition is very important for the healing process. So again, we administer whether it is parenteral or enteral nutrition depending on the need of the patient and what's applicable at the moment. So as I said earlier, if your patient has a lot of injuries on their face and let's say enteral nutrition is not a good option, then parenteral nutrition would be best for that patient. So this is another thing about nutritional therapy. Remember that they can be in hypermetabolic state. So it means that their metabolism can be higher or doubled. So this means that their core temperature might be higher in response to the burn injury. So what's gonna happen? They will be using more oxygen and they're using more energy. So in short, they'll be needing more support when it comes to their nutrition. So what's gonna happen is, again, their enteral feeding will be specific to that patient. calories and protein will be calculated based on the need of the patient. They will also need some vitamins, supplements, and irons that can be given to them. Now, in acute phase, earlier we talked about emergent phase. Now let's move on to acute phase. This time, there is a mobilization of extracellular fluid and subsequent diuresis. So this ends when partial thickness wounds are healed and the full thickness burns are covered by skin grafts. So what do we do with them? So I already discussed this. In addition to that, their bowel sounds are returning. So this is a good sign in acute phase. Okay, and as you can see here, everything is healing and getting better in acute phase. And same thing in here, showing you that this time the partial thickness wounds form eschars, so that's a good sign. And that once that eschar is removed, then reepithelialization begins. For full thickness, your patient might require debridement and grafting. Now, in acute phase, another thing is that when you look at their sodium level, hyponatremia can happen. And this is in response to, when you give too much fluids, it dilutes the sodium. Now, what happens is your patient, once you start diuresing them, the sodium hopefully will get better. And when you give too much, you have to watch for the patient's possible water intoxication also. Now, if you give too much fluid and let's say what happened was the sodium climbs up, okay, that can also happen. So that's why it's very important for us to monitor their sodium level. Whatever we give, whether it's fluids, enteral feedings, oral feedings, or parenteral nutrition, we have to make sure we monitor their electrolytes. Now, when it comes to potassium, remember earlier I mentioned to you about hyperkalemia. So this can happen, especially if your patient has renal failure and has some massive deep muscle injury. This can happen. So you want to make sure you look for the signs of hyperkalemia. Like for example, peak T wave, and let's say you saw ST depression. That tells you that the potassium might be high. And of course, you check the blood. The thing is, hypokalemia can also happen, especially if you've been suctioning the GI using the NG tube. Or let's say you're giving too much of IV therapy without potassium on it. This can also develop. So again, watch for signs of hypokalemia. And the signs are, let's say, presence of U wave, presence of depressed and flat T wave. So you can see that also. So that's why with those that I mentioned earlier with potassium is monitor them and replace what's lost. Or if it's too much, then our goal is to reduce it. Now with infection in here, since remember this patient might be immunosuppressed, so be very careful when you're doing wound dressing on them because they're already at risk to develop infection and they might need antibiotic prophylaxis. So we watch for any signs and symptoms of infection. So you already know if their temperature is very, very high or if their temperature is very, very low. Their vital signs might show that their heart rate is high, their blood pressure is low, their urine output is dropping. That tells you that there might be infection going on. So if there is, we obtain culture, whether it's in the urine, the blood of the patient, or in the sputum, and we check the lactate level because if your patient has sepsis, we have to check the lactate level. Now, we also need to monitor their cardiac and respiratory system even though they're already in acute phase because some complications might arise. So we want to make sure that we intervene timely to this type of patients. And neurologically, your patient might still have altered mental status, so we need to provide patient safety, like delirium. So if they have that, we want to make sure that we put them close to the nurse station, we reorient them, and this can last for years. This can be a sequelae of the burn injury. Now, musculoskeletal, they have very limited ROM, and that's a complication. So that's why it's very important for us to perform passive ROM or active ROM, whatever was best for your patient, because it really helps for the circulation. Now, for the GI, earlier I'd mentioned to you about there's a chance that their bowel sounds might shut down and there are risks for paralytic ill use. So make sure you monitor their bowel sounds, because you don't want to give something in their stomach if their bowel sounds are absent, because that might cause nausea and vomiting. Now, if they're having diarrheal episodes, let's say because the sodium level is imbalance, then you want to make sure that you investigate what's causing the diarrhea. Or maybe they have Curling's ulcer in the GI system. And you might be wondering that what is this Curling's ulcer? So Curling's ulcer is a stress-induced ulcer of the stomach or duodenum that occurs in relation to extreme physical stress, like with burn injury. So that can happen too. Now with endocrine system, this time remember, when your patient had injury, whatever that is, the blood glucose might be elevated and insulin might be insensitive. So this time we have to monitor their blood glucose level and make sure that we give them the proper care. Now, when it comes to management, I already discussed this. This is the summary of what I said earlier. So I'm gonna move on. Okay, this one I already discussed. Okay, I already discussed about wound care. So remember, as you can see, the wound care really depends on what type of patient you had, whether they had debridement or not. Now, this is another thing with wound care. Again, it depends if they have grafts. Do we need to leave it open or not, depending on the need of your patient. Now, if they have excision and grafting, this time is, we need to keep the autograft clean, and that the choice of dressing really varies per patient. Okay, so you see this is just showing you that the grafts might be attached with fibrin sealant, sutures, staples. It depends. This is to show you about the split thickness sheet skin graft to hand. So this is what it looks like, guys. This is the donor site being harvested, and again, it can be from a cadaver. This is showing you that covering the donor site with hydrophilic foam dressing, to promote healing. This is the healed donor site. Okay, so excision and grafting, this is a cultured epithelial autografts wherein obtained from the patient's unburned skin. Okay, and I show you the harvesting earlier. This is an application of cultured epithelial autograft. Look at that. This is a healed culture autograft. So look at that, right? There's an incision and then they did an harvesting there. And I already mentioned to you with excision and grafting, they can have dermal, it can be a dermal substitutes or substitute to the skin that was burned. And again, remember your patient will be in a lot of pain, so we have to pre-medicate them and make sure you perform also non-pharmacological pain measures, pain management measures. And here is this is what I told you about non-pharmacological, like music therapy, relaxation breathing. I already mentioned to you earlier that this patient will need to be moving around, so we need to collaborate with the physical and occupational therapies. I already mentioned to you the nutrition. This is very important for them to heal, and we need to monitor lab values, like for example, monitoring their albumin level. Now, after we're done with the emergent and acute phase, your patient will need rehabilitation. And as you can see here with rehabilitation, again, now this time is everything is healing. And it takes about, 4 to 6 weeks to see those changes, up to 12 months. You might see the patient, though it's healing, you might see difference in the color of the skin. And here you might see some discoloration due to the scarring. And there might be contractures that can happen. So proper positioning, splinting exercise should be used to minimize the contractures. Okay, so this is an example of contracture of the neck. So look at that. Okay. So we want to make sure that we encourage the patient and the caregiver of the patient to take part in taking care of the burn injuries, like performing wound care, some dressing changes, making sure to moisturize the skin and protect the skin from the sun. And, reconstructive surgery can be done, especially if there's a major burn injuries. As I mentioned earlier, the pain management is ongoing for this client. And again, nutritional needs will be individualized, and we need to collaborate with the PT and also OT and encourage and reassure the patient that, they will have enough support for the physiological needs that they have. But of course, we need to assess the emotional support and emotional needs of the patient. So our patients, especially with elderly, they can have unsteady gait, limited eyesight, decreased hearing. So just looking at it, we have to provide patient safety to this patient. As we assess the emotional needs of the patients and the caregivers, is we also assess the burn injury, as they survive this. Remember, the patient might feel guilt, fear of dying, frustrations, and they might develop also other fears or phobia that can occur during recovery. Okay, so self-esteem can be affected, and their spiritual and cultural needs. So we want to make sure that we support our patient. In addition to that, let's not forget the nursing staff. Of course, as we see these burn injuries of our patient, our emotional support is critical and really need by the profession, because we've seen so much. And again, debriefings may be helpful, that can be done by the charge nurse or the nursing manager or the nurse educator. And again, self-care is very important. And this ends my presentation.